from nutrition in India, insights from National Family Health Survey 5, Phase 1 data. I will quickly take a moment to share the broad agenda with you. So this is a 1.5 hour webinar where we will be sharing the overview and launch of the state nutrition profiles that will be done by Dr. Gwen. Then we will have the remarks on the state profiles and on research questions of interest to support nutrition policy in India by Dr. Rakesh Sarwal, who is the Additional Secretary of the IO. Followed by 4 research presentations and then remarks by the panelists. And we'll be ending with question and answer session for the discussion and please. So before I hand it over to Purnima, I would like to just make a few announcements. For the question and answers, there's a Q&A box that you will see on the bottom center of your screen. We request you to kindly post all your questions there during the session, and we will take it up during the Q&A session towards the end of the webinar. If time permits, we will also allow the attendees to raise their hands and unmute themselves to ask their questions directly to the panelists and speakers, but only if the time permits. The presentation and the video of the webinar will be posted online for future reference, and links will be shared with all of you who have registered for the event. Now I hand it over to Dr. Purnima Menon, who is a Senior Research Fellow at the International Food Policy Research Institute and is based in New Delhi. She is the team leader for South Asia Nutrition Programs in IFPRI's Poverty, Health and Nutrition Division. In her work in India, she directs POSHAN, which stands for Partnerships and Opportunities to Strengthen and Harmonize Actions for Nutrition in India, an initiative to support more use of evidence for nutrition in India. Over to you, Purnima, for the welcome and introduction.
Thank you so much, Isha, and thank you to the entire team that has put this webinar together. This marks one of the many important points in our journey in supporting the nutrition community writ large, not just the policy community, but our entire research and program and policy community with sharing evidence and insights and data on nutrition. As many of you know, we have been doing this for, when NFHS 4 was launched as well. We now have the great privilege in a sense of having fairly soon after NFHS 4, at least the release of the first phase of data sheets and reports from NFHS 5. We have been working with many different colleagues this time, particularly UNICEF, IIPS, the Institute for Economic Growth, UNICEF, and IEG to this time prepare a set of state nutrition profiles that are a joint product of our collective efforts. So today we're also very happy to be able to launch that first set. And we'll also use this platform to share some of the ongoing analysis that many of the intrepid researchers in India are doing already with just the fact sheet data that's available. I'm very glad again that we are co-hosting this in partnership with colleagues at Niti Aayog, and very happy to welcome Shri Rakesh Sarwal to sort of co-chair and anchor this platform for us today. It is really for us, I think, a signal and a sign of the commitment and the interest in using data and evidence to shape and inform the strategies for nutrition as we look forward. So I really don't want to take more time. I'm going to hand it over first to my colleague, Dr. Phong Nguyen. I think, Isha, you will probably be introducing her, who will sort of present first, some of the work that we are doing in this collaborative effort. And then she will describe the state profiles. And then we'll have a set of remarks from Shri Rakesh Sarwal. So first back to you, Isha. Thank you so much.
Thank you, Purnima. I now welcome Dr. Phong Nguyen, who's a Senior Research Fellow in the Poverty, Health and Nutrition Division at International Food Policy Research Institute. Her research interests are in the area of maternal and child health and nutrition. Currently, Dr. Nguyen is a team leader of the data and evidence to support policy implementation component for POSHAN Phase 2, which stands for Partnership Opportunities to Strengthen and Harmonize Actions for Nutrition in India. She is also leading the evaluation for maternal nutrition interventions in Bangladesh and India. Over to you, Fung, and I'll unshare my screen.
Hello, can you all see my screen?
Yes, Fung, we can see your screen.
Okay, thank you. Sorry for a little bit. So thank you. On behalf of the IFPRI team, I would like to present few works that currently that we are working on understanding the Indian progress on nutrition and also launch of the SNP profile. First, I would like to really thank all the collaborators to have worked with us for the last few months from the time that the fact sheet have coming out, also in the past long, but currently with all the data for minutes 4 and 5, including the NETL, the UNICEF, the IEG, and the IIPS. All your contribution and the comment suggestion have really helped us to get the data more meaningful and relevant for India. So from the fact sheet and the state sheets that have just recently released from December last year, we have worked together to produce several products. Among them, the multi-state presentation, the state presentation for 19 states. Actually, we have 20, but the few states have a union territory very small. And then we also prepare the state nutrition profile that we are launching today. We also work on the state level success story in case of Bihar and ongoing work for other states also. In terms of the district level, we work for the district nutrition profile and the district level success story on the topical topic, just as the stunting anemia or IYCF. To just give you a little bit of overview for each product, just example for multi-state presentation, we present the multi-step change in outcome, indeterminate, and intervention coverage between the 2 years 1996 and NFHS4 and NFHS5. And then we also offer the initial interpretation for trend. Just example, for each of indicator, we present the trend over time for different states in India. And then we also make the map to compare over time between the district level. We also highlight that what is how many districts are with in the cutoff of threshold with the significant concern based on WHO threshold. And then for the we also calculate the burden of the problem. Just example for the underweight here, we use the prevalence together with the population in that to calculate how many head count. So we make the map of the burden. Just example here, we have a burden of number of children who are underweight for about 340 districts that with available data. And among them, we highlight about top 100 high burden underweight district, like the dot point here in this map. So among these, we found that Bihar has the most district with a high burden, about 32 districts among the top 100 high burden, followed by Maharashtra, West Bengal, Gujarat, and many others. And then we're also able to list out what is the top high burden district. As example, here the list is a little bit crowded, but for you, for snapshot like what we are working on. For the state presentation, for each state, we also make a set of about 50 slides to talk about undernutrition outcome, overweight, obesity, and non-communication disease, the immediate underlying and intervention across 1,000 days. And right now, we already complete the presentation for 19 states, and it's ready for you for any state that is needed. For the state nutrition profile, I will talk last because that is a key one that we want to launch today. And then we also work with the district nutrition provide with the aim to create short profile based on POSHAN ambient monitoring framework of outcome, immediate and underlying determinant, and also the program coverage. Right now, we have complete the indicator selection. We are ongoing work with the design, and we hope that we can have a plan to finish the first round of district in the next month or so. So in this one, we can see that for each district, we have a set of different indicators. We compare the 2 years between 2016 and 19. And we also compare that district with the state level, just like Bihar here. So we can see how the state behave over time and how it compares with the overall at the state level. We also work with the state level success story case study that my colleagues trust me will present about this later. So I will not go to that. So now I really want to focus on the state of nutrition profile. Again, really appreciate all the comments, suggestions, and valuable contribution from different partners here with the logo here that have together with us during that long process to get to the product today. So inside this one, what we can see, first we can see the chain for set of key nutrition and health intervention and coverage over time. Here we look at 3 time points from NF3, 4, and 5. And then we also use a censored level of 1121 to project the level and calculate the burden of underweight, undernourishment, overweight, and non-communication disease among children, among women, and in men. We highlight the prior district and number of districts in the state with the public health concern. We color-coded the dashboard to compare the coverage of nutrition intervention across district and across the state. And finally, we also provide some key takeaway and area for improvement for each state. So just example, for nutritional outcome, we compare the trend over time. Just example here for Bihar, we compare the trend over time among 3 rounds of NHS 3, 4, and 5 to see how it happened. And then we also compare, we have the line to see with the Indian average to see how the state perform compared to the overall national average. We have that for undernutrition among children under 5 and also for the women 15 to 49 years. And then for each of outcome, we make the map with the burden of the problem, like how many head count, because even the prevalence is not much high, but if that district have a lot of population, then it still come a big burden, like the hotspots that we need to focus. So we make the map for stunting, for anemia, for all other outcome. And then we select the highest burden district in terms of each outcome. We also highlight the district with number of public health concern. Just example here, Bihar, all the district is in the public health concern based on WHO cutoff. We have a similar output for all other undernutrition outcome. We also compare the burden of overweight and obesity and other NCD to see how it emerges over time, because currently they have a lot of concern about overweight obesity have emerging in India. And then we also compare the 2 years between 19 and 16 to see which district performs the worst, which district performs the best, and what is the currently, how it look like in each district. In terms of nutrition determinant, we'll provide a similar indicator for different indicator, but similar comparison between the 2 rounds of NS4 and 5. Also highlight the worst performing, the best performing, and the currently what district has the top coverage, and that what is the perform the best based on the most current data. We do the similar thing for underlying determinant, like maternal determinant, household determinant. And then we have that for coverage of nutrition intervention across continuum of care during pregnancy, during delivery, and during childhood for all the indicators across time that we can see and compare. And then we also make it a little bit more easier to see by making the dashboard color-coded at the district level So here, if we look at the column, we can see how that indicator behave across different districts. Just example, iodine here look like it's very good, but for ANC here is still really red in almost every district in Bihar. Then another way to look at the data, you can look across the row, and then we can see how that district perform across different indicators here. So it really gives the state and the district to see how they perform and what is the areas that need to be improved. Again, we also highlight which district have the worst and the best performing and what is currently in the top coverage compared based on the current data. And finally, we have the key takeaway for district. That's very difficult to put all the things that's inside in one small. So that's why we try to give the key takeaway that the main one that need to improve from the state. And then finally, we have a definition of all indicators we use in this SNP. So please join us to really launch this profile. And here we provide all the links that if you click on that, you can easily to see that the SNP and also other products that can be see here. So just example, if you click on that, you can see that all the data nodes for different districts are here for West Bengal, Tripura, and many others that can be easily seen here. Thank you for your
attention. We can still
attention.
see your slides. We can't see the web page. Can you please show the web page?
Oh, how can I do that? Maybe Isha.
Okay, I.
Thank you. Yeah.
Thank you so much, Poon.
Isha, I'm happy to share the web page.
Okay, thank you. Thank you, Poon.
Okay, everyone, thank you so much. You know, usually when we do these launches, the last time we did it, many of us were on a stage together and holding up those profiles in our hands. But today in this virtual world, where of course we're very happy because so many more people are able to join us than if we host these in person. But this is where you will be able to find these notes. They are available for all the first phase states. And look the way that Fung has described them. You can just click through to a state and then click to download the PDF and you have that available. We invite you to download them, to use them. If anyone feels that they would particularly like to have printed versions of them available, please let us know. We have not yet made arrangements for a lot of printing again in this new and virtual world, but we understand that people are gathering that sometimes print is useful. So that's all. Thank you again. Big thank you to the entire team of people at IFPRI, at NITI, IEG, ID Insight, UNICEF. This was truly a collective body of work by all of us together. You will find the profiles as Fung described them. And then at the end of the page, the names of all the different contributors and a suggested citation if you wish to use and cite these. Again, thank you very much. Let me now hand over back to Isha so she can introduce Dr. Sarwal and we can have your comments and insights, Dr. Sarwal. Thank you. Isha, back to you.
Thank you, Purnama. I welcome Dr. Rakesh Sarwal, who is the Additional Secretary NITI Aayog. Dr. Sarwal is a senior IS officer and holds a doctorate degree in public health from Johns Hopkins University, USA. He has served in the social sector in various capacities in the northeastern state of Tripura and Government of India. As advisor health and planning commission, he was instrumental in preparing the 12th five-year plan. Over to you, Dr. Sarwal.
Thank you. Thank you, Isha. I'm privileged to be present here today in this webinar on Towards Progress on Nutrition in India, Insights from the National Family Health Survey, the 5th phase 1 release. Let me thank the partners, IFPRI, IEG, Indian Institute of Population Studies, Mumbai, as well as UNICEF for having done this fantastic job of demystifying and presenting the data on nutrition in a format which is very easily understandable, comprehensible, and actionable for the stakeholders at the state level, district level, and the sub-district level. I think the task has been brilliantly accomplished, and I'll just try to list out what are the key takeaways from this methodology of disseminating the data on nutrition. So obviously data is important and nutrition is critically important at this time, because if we have to use a demographic dividend, then we have to make it sure that our nutritional levels are controlled in children, women, and the population at large. And data is a reminder, is telling us where exactly our pain points are and what action is to be taken. So data is critically important, and occasionally we have, over a period of 2-3 years, longer than what we would like, we have data coming from our surveys. And the beauty of this exercise is manifold. I will just list out some of them. One is that it has a panel information. It presents over the last 3 rounds how the information, the trend, the delta is beautifully blocked out in graphs as well as tables, not just on the outcomes, but also the determinants. And determinants, immediate determinants, the underlying determinants, but also the service coverage for the stakeholder to see what is it that has improved and what is it that is responsible for a deterioration. Second innovation is the burden concept. It's not just the prevalence which is important, it is the burden, which is the number of children anticipated in that age group, in that district. And by multiplying the prevalence by the expected number of children, it brings out the problem from the administrative perspective, and thus therefore points towards where is it that attention needs to be given and where it will be most useful. So that is the second big thing. Third thing I think is the learnings coming out of this in terms of the summary that they presented, the best practices, the worst ones, as for all these 3 determinants, that is the outcome, the determinants as well as the coverage, make it amenable to action. And this is summarized beautifully in the key takeaway points at the end of each of these beautiful data notes. And that is the kind of summary which is highly actionable. So when NITI teams go to states, our teams can present this to the highest political and the bureaucratic executive over there. And at a glance, you know how the state is performing, what is it that needs to be done. So the actionability is the other big thing out of this. My suggestion would be, it's good that all this data is already posted on the web. The list of best and the worst performing districts are available. My suggestion would be, for the benefits of the researchers, to present the raw data. Even with the lack of unitary level data, there is a lot of data points that have been used here. So my suggestion is to put the raw data in a CSV file for the researchers to utilize it and try to decode the data and decode the information behind this data in terms of the determinants of best performance, the worst performance, what has an influence and why did this change take place over time. So that kind of an activity will really help us. And of course, that is again an activity, an area in which we all research community need to work into to look at what the data tells us, the reasons for the change, and also what it doesn't tell us, which is also very important, and unearth the reality behind the numbers so that the actionable points can be taken. Now, I would also like to share some of the insights that have come out from this analysis, which are quite startling actually. The WHO public health concern category of stunting is there in 67% of the districts. Wasting is there in 80% of the districts of the ones in which NFHS 5 data has been released. Anemia in children, even higher, 92% of the districts have anemia in children as a public health concern because it is more than 40%. Underweight is in 53% of the children, and overweight is a increasing problem present in 2% of the districts. So these numbers tell us the extent of the problem that we are facing of the nutrition of its different dimensions in the country. The problem is not the only one. There are solutions hidden in this data, and I would like to share some of these which have come to our light, like stunting. If we look at the range of stunting prevalence in different districts of the country, the best performing, that is the lowest stunting, is in Manipur, Vishnupur district. A stunting prevalence of only 15.5%. And if you look at the worst performing district in the country, it is Bihar. It is Purba Champaran. So you see that there is a 3x multiple between the best and the worst performing. This holds lessons not only in terms of what the state governments can do, but what we as a country can do to learn from within the districts, within the states, and make this difference possible. Another insight coming out of this is the delta, is the change in the indicators over the 2 and the 3 rounds of NFHS. I'll just cite some of them. Like the best performing district in terms of improvement in stunting is in Shihokar district of Bihar. The improvement is 18.6% over the 2 NFHS 4 and 5, which is not a long time interval. It is maybe 5 years time, and the difference is roughly 3 percentage points in every year, which is remarkable. And similarly, Gulbarga in Karnataka has had a change of 17.7%, and similarly, Sikkim West District has had a change of 17%. So these contrasting data, they tell us an important story of the possibility that measurement, the interventions, and the lessons that data holds can be applied towards policy. I'll continue in terms of the other indicators as well, which are as startling. Wasting, let's take now wasting. The least prevalence of wasting in India is in Mizoram, Mamit district, which is incidentally an aspirational district, 7.4%. And the worst one is in Maharashtra, Thane, surprisingly. It is in Pune, and again in Maharashtra, which is 31%. So we see a 4x multiple between Mamit and Pune. There is a 4x multiple in terms of wasting, which again holds lessons to understand. Of course, Mizoram is a highly state where non-veg is the diet. The animal protein in diet must be contributing to it, but there are other lessons in terms of program delivery. And what's wrong in Pune that the number is such an high is really worth investigating. Similarly, look at the change in wasting from this database. We see that the best performing is Gadag district in Karnataka, an huge improvement of around 30% in this 5-year period, roughly 6% improvement in wasting in this between the 2 rounds. And similarly, South Garo Hills in Meghalaya and Dharwad in Karnataka. So there is something happening in Karnataka which is making a quick difference, a rapid difference in the levels of wasting of the children. And of course, there are research and there are evidence to that effect. But this data throws light to the need for similar interventions in other parts of the country. Talking about anemia, we see that the prevalence is as high as 67% again in Thane, Maharashtra, while in terms of lowest anemia prevalence, 28% in Meghalaya. East Garo Hills again is a multiple of 3, and that again holds lessons on what can be done. In terms of delta in anemia, we see that South Garo Hills, Solan in Himachal, surprisingly Solan in Himachal and Chamba in Himachal, they made a huge difference of South Garo difference of 41%. And Solan of 21%, Chamba of 19% over this time frame. So the stories, the success stories tell us that the change is possible, it is happening. It is a question of looking at the reasons for these changes as well as to imbibe them. And similarly for the underweight also, there are a lot of hidden stories in this. So I would summarize that I would compliment again the teams at IFPRI, IEA, IIPS, and UNICEF for bringing out these beautiful data notes. They are very, very usable for policy. I would urge our researchers to look at what is working, what are the determinants of the change for the better, so that policy inputs can come out. And while doing this, not to lose sight that a large part, roughly half of our children and women are not going and getting the services of ICDS. So what is the impact of ICDS? What is making a difference in the population covered both by the ICDS and not by the ICDS, and how the interventions both for the community and the program can be tailored to make a difference of the kind that we have just seen and which is absolutely remarkable. So with these few words, I thank again the organizers for getting me here and reiterate the commitment of NITI Aayog, of the Government of India, to make a difference in nutrition. Thank you very much.
Thank you so much, Dr. Sarwal. Really very privileged to have you and your team be joined with our teams and the broader nutrition community in this. I think I speak for ourselves and for the large nutrition community that is gathered here. We have almost 200 people, over 200 people here today listening, which just signals a tremendous amount of interest, but also tremendous commitment to work jointly with you and to take things forward from here. I would echo what you said, which is that the data notes, they are a means to an end. They're not an end in and of themselves, and their value and their returns to society will really come from how they are taken on and used. And I know many of us here would be pleased to collaborate across India in helping to see these data being used to diagnose actions, identify successes, and take things forward. So thank you again very, very much for your great collaboration and your great interest on all of this. I will hand it back to you now, Isha, to take the rest of the program forward. Dr. Sarwal, I know you have to leave at some point soon, but I do hope you can also listen to some of the insightful presentations that many of the intrepid researchers, as I mentioned, are pulling together based even on just these limited available data at this point in time. We welcome you to stay for as long as you possibly can. So Isha, back over to you, please.
Thank you, Dr. Sarwal, and thank you, Purnama. Now we will start with the research presentations. And now I would like to invite first Dr. Divya Nair, who will be presenting on analysis of nutrition outcomes and process indicators, complementing administrative data with NFHS 5. Divya Nair is a director at ID Insight based in New Delhi. She has worked effectively with governments, multilateral funders, and NGOs for almost 15 years. At ID Insight, Divya leads teams across sectors to identify key challenges, design, execute high-quality analytical services with an aim to catalyze evidence-based decision-making. Over to you, Divya.
Hello, good afternoon, everybody. It's a real pleasure to be here, and congratulations to the IFPRI teams. We have used these data notes at the district and sub-district levels in the past, and they've been really invaluable. So congratulations, and really looking forward to digging in. Today, what we were going to do was present a little bit about some of the work that we've been doing with actually Dr. Sarwal's team and with SIF, where we've been looking at the convergence or the congruence between HMIS data or administrative data and NFHS. And just given the richness of NFHS data, the sense is that it really is the gold standard in the country. So how can we use it to improve other data sets and other data sources, and also provide insights more regularly? So I will jump in and give you a sense of what we did. Next slide. And so we basically assessed, the difference between administrative data and survey data. We looked at HMIS and we compared it with NFHS 4 and 5. This was because, all of NFHS 5 is currently not available. So we used both NFHS 4 and 5. And so on the one hand, we looked at data quality. And on the other hand, we looked at, generating insights. And the reason was, next slide, was that administrative data really provides a pulse on what's happening much quicker than the survey data. And so the objective was to establish a use case for using administrative data more regularly and periodically, and using the NFHS data to kind of give us a sense of how accurate it, NFHS is. So this turned out to be a significant exercise in the sense that we analyzed data across the country. So this is 735 districts. We looked at 4 years of data because we wanted to get a sense of the trends in HMIS and really understand the quality of HMIS data. We ended up selecting around 21 indicators, and this was based on the usefulness for Niti Aayog in terms of the kinds of indicators that they would be looking at over time. We analyzed both state and district level data, and we used a variety of methods. So we used multi-level models to get a sense of trends over time at the state and district level. Next slide. And basically, I just want to step back because, we're talking about NFHS, but just to remind you about the difference between the two is, NFHS is a national survey. It provides large scale estimates of the population. The target population in this case is, pregnant, lactating women, mothers, and children. Whereas administrative data, really provides you a sense of the data that's collected by providers. So the difference is, NFHS data is collected by trained surveyors. It's collected every few years, whereas HMIS data is self-reported by the people who are providing services, and HMIS data is also available much more frequently. Next, please. And so there are some clear pros and cons in terms of these two data sources. One is that, the coverage, NFHS covers the entire target population, whereas HMIS really collects or covers, only those who are actually accessing public health systems and who are also being registered in the public health system. So those who are not included for various reasons in the HMIS are missing in, analysis. Similarly, there's a difference in recall periods. Often the recall period, because it's less frequent in NFHS, is longer, whereas HMIS, the recall period is shorter, quicker. And then there's an issue of denominator estimation. The challenge here is that, whereas NFHS, because it's a survey, it's much more simple and straightforward to calculate the denominators. For HMIS, the denominators are calculated separately. It's, often there's an annual exercise that's carried out to collect information on these denominators. In the context of COVID, some of that didn't happen. So that really was challenging for us in terms of calculating some of these indicators. And frequency, I already covered, as that's where I'm hoping that HMIS and NFHS can really work together, because NFHS is much less frequent as a survey, whereas HMIS is really real-time live data that's provided almost monthly. And so, the frequency is quite different, but hopefully it can be complementary. Next slide, please. So quickly, I just wanted to give you a flavor. This is still, not fully released. So we're just sharing some preliminary results with you. When you look at the internal consistency of HMIS, actually it's pretty high because the HMIS system, they themselves are spending a lot of effort in terms of cleaning and the data quality aspects. So only 5% of the data is missing. There's very, small proportion that are outliers. And, similarly, we conducted a few more checks. A quarter of the data, however, is logically inconsistent. And that is coming often from, just the difference in the way the numerators and denominators are calculated. And, we can talk more about that if people are interested. But today the focus is really on the external consistency piece, where we are looking at the overlap between NFHS and HMIS, because we compared NFHS data with HMIS data. And we conducted two kinds of benchmarking exercises. One was district level benchmarking and the other was state benchmarking. So for the district benchmarking, we calculated point estimates using NFHS 5 data. And we basically had a margin of error that we calculated for these point estimates. And then we saw whether the HMIS data kind of fell within these margins of error. So that was the district benchmarking that we did. For the state benchmarking, it was a mix of NFHS 4 and NFHS 5. Ishan, can you go to the next slide? I can show you the visual. So the district level is on the left, where we saw what the overlap was. And the state level benchmarking is on the right-hand side, where you see that we were able, because we have more data across states, but if we use both NFHS 4 and NFHS 5, we basically compared whether the ranking was similar of these two estimates, point estimates. As a caveat, we only looked at a few indicators. So on, for the district level estimates, we looked at 3 indicators. One was, ANC checkups, institutional deliveries, and breastfeeding within first star. And then for the state level comparisons, we looked at a few more indicators. And this was really the reason this was driven largely by, as I said, the definitions of these indicators are often, not comparable. So we could only choose from a very small subset of indicators which were really comparable, given the recall periods, the difference in denominators, etc. But basically what this gives you is a sense that, the data is congruent and there is state variation, and it gives you important information in terms of the quality of HMIS data from across states. Next slide. So I just want to reiterate, and this is also drawing from a report that we had co-authored with Niti Aayog and IFPRI, where there is this complementarity across these sources of data, and really given the importance of tracking how we're doing in nutrition, and to answer some of the questions that Dr. Sarwal was raising in terms of why are there differences within states, and how do you really monitor what's happening. What we are saying is we should really use HMIS data to track progress. But then as you go further down and as you're trying to do strategy refinement and policy advocacy, etc., you really need to complement it with as much other data as possible. And NFHS going back is the gold standard in terms of giving you a sense of how the outcomes are moving. And basically it gives you a more full picture if you use all these data sources. Next slide. And I just wanted to give you a flavor of the kinds of insights we got. So, this gives you a bit of the COVID effect, which we don't have in NFHS currently, right? And so this is much more recent data than is available in NFHS. We're looking here at full immunization, and we're looking at full immunization over time. So we have, from 2018 to 2021. As you can see, in 2020, in April, there's this big fall in fully immunized children being reported in the system. But the interesting thing is you also see that there is this seasonal effect. Over time, every year there has been this slight seasonal effect, and that is because of the way the data is entered into the HMIS system. There is a refreshing process that happens around that time. And then the other thing, just looking at this graph, what is reassuring is that you see that even though there was a huge drop in service provision, it actually has kind of come back and almost kind of converged back to pre-COVID times. So this kind of gives you a sense of the importance of having more, recent and the latest data, of having data over time that's, being collected, hopefully, in the same way. Next slide. And finally, I just wanted to end with a few ideas for improvement on both HMIS and NFHS, just because we've been looking so closely at both of these. Shan, I can't see the slide. I don't know if, yeah. So basically, NFHS, the point that we're kind of making is that it is not frequent enough, and it really does need to become more frequent. And some ways to potentially make the turnaround shorter could be to, for example, reuse household panels, to conduct remote trainings, because that's something that would just hasten the process given the scale of NFHS. Similarly, given our experience in terms of conducting surveys, just having more automation just increase the turnaround time, because currently our sense is that the data is it just takes long to collect and then to also disseminate and make available. Similarly, another idea could be is have a subset of indicators that are collected more regularly, and potentially even consider collecting them via phones, because over COVID, all of us have had experience in terms of using phone surveys, and we've learned the pros and cons of that. But it is something that is worth considering, just to make sure that there is more regular data available. And then for HMIS, data quality, of course, is something that needs to be continued. There is a lot of effort going in currently in terms of improving the data quality. Reporting on the quality of that regularly would help. And similarly, I hope I made my point in terms of just using, regularly using administrative data to generate insights. I think regular use will hopefully also improve data quality, but more than that, improve, evidence-based programming and decision-making. And, to facilitate that, I think there's a whole bunch of ideas that we have, but one of them is really standardizing reporting formats, because we still see that there is difference across states and sometimes even across districts within the same state. So those kinds of small tweaks will help just making it better quality, more accessible, and hopefully, just enable more evidence-based programming. I'll stop here, and I hope to share our final report with all of you at some point soon. Thank you.
Thank you so much, Divya. Thank you for raising this important issue of data quality and the reporting formats, as well to have a common set of indicators across the different reporting and survey formats. And I know a lot of organizations, including Institute for Economic Growth, IFPRI, IDINSIGHT, we are working towards it, and we hope to have to soon have better quality HMIS data. For our next presentation, I would like to invite Mr. Divik Sinha, who will be presenting on stunting under 5, looking at the intra-state level variation across Karnataka. Divik is a researcher at the Urban Informatics Lab at the Indian Institute of Human Settlements. The focus area of his current projects includes domestic work, population projections, migration, and unemployment. He has mainly worked on data sources like NSS, NFHS, and PLFS, and the population census. Over to you, Divik. Over to you, Divik. And Divik, you'll be sharing your screen, right?
Yes.
Okay.
Is my screen visible?
Yes, it's visible.
Yeah, hi. Good afternoon to everyone. So, like you said, our research has been on stunting under 5 in the interstate variation across Karnataka. Our lead researcher, Divya, was unable to be here today, so I'm taking her place. And yeah, so a couple of caveats before I begin. Most of our analysis is in a very preliminary stage, so take it all with a pinch of salt. And at a certain point, we switched to using NFHS 4 data because NFHS 5 unit level data hasn't been released. So yeah, so when we look at the NFHS 5 state level data for Karnataka, what we notice is that the stunting rates across the state haven't really moved all that much. They've moved from 36.2% to 35.4%. But if you look at the intra-state district level variation, it's quite high. As Dr. Sarwal had mentioned, we have a couple of districts here that have performed extremely well, like Gulbarga and Bellary, that have reduced the rates of stunting drastically. But at the same time, there's a lot of districts that have also had the opposite, an increase in stunting. And our primary sort of research question is to see why there is so much intra-state variation across this indicator happening. So what we did was we spatialized it. And what you can see here is that between NFHS 4 and NFHS 5, there is a very clear pattern of stunting being much higher in northern Karnataka. And while the differences between districts have slightly reduced in NFHS 5, the pattern that North Karnataka is much worse off than South Karnataka still exists. So our next step was to club these districts together as administrative regions and study them in that way. So the reason we chose administrative regions is twofold. Firstly, it's just more complicated to study 30 districts at once, and it was just more feasible to take them in these groups. And the second thing was that some of the budgetary allocations that are made by the Karnataka government happen on the basis of these administrative regions. And that was an aspect that we wanted to explore further. So we took this into account. So what we see is that taking these regions into account with socioeconomic indicators using NFHS core unit level data, what we see is that taking into account the region, whether a child was in the urban or rural part of the district, what their caste is and what their wealth indicators is. For the urban rural part, for the caste part, and for the wealth, we see patterns that we would expect, that being richer helps you be not stunted. The same thing with caste and urban rural, very sort of expected patterns show up. But even if we take those into account, what we see is that there is a very statistically significant difference between the different regions, the administrative regions that we took into account. So being in South Karnataka is statistically significant, creates a statistically significant difference in terms of reducing stunting outcomes for children. And this exists even while we take into account socioeconomic variables. So this was a logistic regression that we did. As you can see here, these are the stunting rates for these four district regions, and you can see very clear differences between them. Kalburgi and Belgavi are the two districts, the two northern administrative regions, while Bangalore and Mysore are the two southern administrative regions. We expect a similar pattern to hold for NFHS 5, and that's something that we're looking forward to seeing once the unit level data exists. Again, this was just the urban-rural differences that also exist between the different administrative regions. The same thing with wealth, which gives us very statistically significant differences, and the same thing with caste. So this was sort of the result of this regression, where you see that these differences between the regions exist not only just across the general population, but also across all socioeconomic subgroups of the population. So whether you take the poorest or middle income groups or the richest, as well as urban rural areas, or different caste groups, these differences do exist. So in this slide, what you can see is the differences between Kalburgi and Mysore, which are the worst to do region and the best to do region. And no matter what slice of socioeconomic strata we take into account, there are very statistically significant differences between the two regions. The next thing that we had in mind was looking at all of this with regards to ICDS indicators. And what we noticed was looking at another research from 2015, what we found out was that the number of beneficiaries for each Anganwadi center in North Karnataka was much higher than in Southern Karnataka. This is based on slightly older data, but some of our preliminary projections for 2020 also showed that the pattern is very, very similar to this. And we would also want to look at that further with newer ICDS beneficiary data. One big reason for this could just be that Anganwadis are created on the basis of total population and not child population. And in North Karnataka, the child population ratio is much higher as opposed to South Karnataka. So in terms of the future aspects of our study, we want to see how all of this stacks up with the NFHS 5 unit level data and whether these patterns continue. And also currently we've only looked at it in conjunction with socioeconomic indicators. And we also want to see this in conjunction with maternal health indicators as well as other child health indicators. And access to Anganwadis is another big one that we wanted to look at. Another thing that we want to see is look at this look at the stunting prevalence along with policy and infrastructure, and see how the ICDS budget allocations differ between North and South Karnataka, and how the number of beneficiaries has changed over the last 6-7 years in both of these cases, as well as even if all of these were to be equitable, how would the infrastructure differences between the two places, the health infrastructure differences between the two places play a role in this difference in stunting. Yeah, so I will stop here. That was our very preliminary research. Thank you so much.
Thank you so much, Divij. And this is, I think, the first time we are collaborating with your organization as well. And we hope to keep this collaboration in the future as well. And now I would like to invite our third speaker, third presenter, Dr. Sheila Veer, who will be presenting on NFHS 5 state-wise trends of interventions addressing child undernutrition. Dr. Veer is a senior public health nutrition consultant and the founder director of a Delhi-based professional agency, Public Health Nutrition and Development Center, New Delhi. Dr. Veer has over 35 years of experience of working in the field of nutrition program and was with UNICEF India for over 20 years, where she worked closely with the central and state governments and provided strategic and technical leadership for policy formulation and implementation of nutrition programs. I will be sharing the screen for Dr. Veer. So just give me a second. Yes.
Yes, thank you. Thank you, IFPRI team, for inviting me to give me an opportunity to present this study, which we had undertaken in April, May, right when the NFHS 5 data was coming in. The idea was to understand what was the trend and to understand, to synthesize the data with reference to what program direction we should take. And this is based on the Operational Research Foundation report, which is available. It is already loaded. It's an occasional paper of 21. Yeah, thanks. Next one, please. Next slide. So we studied the trend with reference to, besides the child nutrition indicators, the direct nutrition health interventions, which address the immediate determinants, what was happening, and nutrition sensitive interventions, because they seem to be doing very well when I looked at it. So we thought it would be a good idea to look at what is happening in both of these areas, and immediate determinants and underlying determinants. With reference to underlying determinants, we looked at the women's nutrition and maternal health services, low and high BMI, antenatal care, IFA, adolescent marriage conception. And with reference to empowerment of women, we took it as a proxy because there's nothing, it's not assessed directly by any indicator. 10 years of education, owning their own mobiles, as they say this time, savings bank, having savings bank account, domestic violence also I looked at, as well as access to clean fuel, because access to clean fuel means more time for mother. She's empowered with more time at her hand. Water, hygiene and sanitation issues were also, indicator was also looked at. Next one, please. Yeah. So we compared NFHS 5 and NFHS 4, which is really 2016 and 19 data. And we looked at, when we look at the data, which is much more detail has been done by IFPRI now, 3 states reported stunting decline of at least 3 percentage points. Bihar, Manipur, and Sikkim. Bihar was discussed in detail right at the beginning. And 13 of the 22 states showed an increase in stunting trend. And of this, what is interesting, 6 out of 13 had over 3% point increase. And interestingly, I think we need to probe in Goa, Himachal Pradesh, Kerala have shown an increase in the rate of stunting, much higher than other states. Telangana, Nagaland, Meghalaya also come in this group where you see over 3% point increase. Then substantial increase in stunting rates were observed in 2 of these 3 states. Goa from 20.1%, which was the lowest in NFHS for these 2 states. Kerala 19.7. You can see the increase to 25.8 and 23.4, which is a big puzzle. And I'm sure when IFPRI data comes, we will be able to dissect it more and understand. All 22 states showed an overweight trend in children. Now, when we studied the child stunting and overweight trend, we also looked at the underlying determinants and the services that were being offered. Next slide, please. So nutrition sensitive interventions show an unusual, very high coverage in NFHS 5, which is very encouraging, which included health services. And we see that increase in all except 8 states. And only in 3 states it was a decrease. Undernutrition declined in all except 5 states, undernutrition in women. And it was below 20%, which is the which is what defines undernourished population of women, except in 3 states. Anemia, of course, showed an increase. Overnutrition was sharp increase in 16 of the 22 states. So sometimes we have to wonder whether it's really poverty which is causing a lack of access to food, or we have to look into other issues and not jump at poverty issue all the time. I think there are many things that we can do in such a situation. Marriage below 18 years, positive trend except in 3 states. Conception below 18 years remains high but stable. In 5 states, it was over 10%. Mothers with minimum 10 years education, the span, the NFHS 4 and NFHS 5, the years it is only 4 years gap, so we see a slow progress. But in 4 states, and of these I mentioned in the earlier slide, 3 had over 3% increase in stunting, came in one of the highest lot. Kerala, Goa, HP, and Lakshadweep have over 66% women who had completed 10 years of education. And we know that this is one of the primary underlying factors which affects stunting. Women empowerment, I looked at it, wondered what to do, and I thought it was best to look at these proxy indicators. Possessing own mobile phones, it says own mobile phones. It doesn't say family owning. Own mobile phones, personal, own bank savings account, access to clean fuel, domestic violence. Bank account significant increase we see in these 4 years, which is really remarkable. We see over 75% in 16 of the 22 states, whereas in NFHS 4, over 75% is only in 3 of these 22 states. Mobile phones increase in all states of over 75%, which is 10 out of 22. In NFHS, it was only 3 out of 22. Clean fuel, access to clean fuel, over 75% is now 11 out of 22 states. NFHS 4, it was only 1. Domestic violence reduced in 16 of 22 states marginally. But we can see that there, because of a number of national programs, there has been a significant increase in these underlying factors, women empowerment, as well as very good coverage of the health services than before. In 4 years, there is a significant increase. So is in the water sanitation facility. Sanitation over 70%. And of course, we will have to look at the district data. This is just giving a state trend. Water source also has shown as an improvement. So underlying nutrition sensitive interventions which address underlying determinants seem to have made a big difference in the 4 years between 2000 NFHS 4 and NFHS 5. Next one, please. Next slide. Now, intervention addressing immediate determinants. Here there's a lot of disappointment, and I think this is a wake-up call for us with reference to nutrition interventions. Full immunization coverage is increased, of course, ORS with zinc. These are health services which have shown great improvement. Over 70% coverage in NFHS 5 is in 18 out of 22 states, which is remarkable because it was only in NFHS 4, it was only 9 out of 22. And we have one state, I think, which has about over 90% coverage. I think it's Goa. ORS with zinc also is over 60% coverage we see in 14 out of 18 states. And in NFHS 4, it was 8 out of 18. But when we come to EIBF, early initiation of breastfeeding, there is a decline. And there is the substantial gap between institutional delivery and EIBF, which remains. We have not addressed the issue, it seems. EBF, exclusive breastfeeding, only marginal improvement. We don't measure effective feeding, so we need to somehow understand whether the breastfeeding which we are referring to as exclusive breastfeeding is being appropriately done and is effective in feeding of the baby and weight gain. There are a lot of problems here of latching, how to hold a baby, how to empty the breast, which remains, I think, again, programmatically a weak area. Complementary feeding, we saw timely introduction, declining trend in 9 out of 22 states. Diet adequacy, remains extremely low. It ranges from 5.9% in some states to 29.8%, and is declined in 5 states. And over 20% adequacy coverage was adequacy in only 6 states was reported. This is much lower than other Asian countries, South Asian countries, where it is up to 60%. For even I think Malaysia also it is about 50%, and in Vietnam it is almost 60%. So diet adequacy coverage is extremely low, and it is a primary concern when I look at it. Next one, please. Now, interestingly, I thought let's look at these 3 states, Goa, Kerala, HP especially, where there was an increase of 3%, 3 power point percentage increase. And in case of Bihar, Manipur, there was a decrease of over 3 percentage points. In case of Goa, Kerala, and HP, when we look at it, everything, all the underlying factors are really superb. They couldn't have been better when you look at a state data. And there is, of course, always scope for improvement, but even then, I think it's so much better than the rest of the, compared to other states in the country. Complementary feeding diet adequacy remains very low coverage, but increased. However, there is an increase. But there is an increasing trend in overweight, obesity in both women and children. Again, this points out that I wonder if the diet adequacy of obese children are also maybe it is getting overestimated, because obese children also may be covered as adequate diet. I don't know. I think IFPRI analysis may be able to answer that. And over 67% girls had over 10 years of education. Higher coverage of MCH services, immunization very high, over 70% in all these 3 states. WASH is very good. Substantial increase in coverage of women. What is the problem? The problem seems to be in feeding of the baby. It seems to me when we look at the data, it is puzzling, but this is what comes out, that we have been able to address the underlying factors, services which are addressing the underlying determinants through various programs, but our own programs of nutrition, which are supposed to address infant and young child feeding, remains far below what should have been achieved by now. Bihar shows a substantial increase. Of course, Bihar started off with a very lower, had one of the highest stunting prevalence rate in NFHS 4, but they show an increase in coverage of nutrition sensitive interventions, which is very substantial increase, and they show an increase in timely introduction of complementary feeding. But adequacy is not, there's not much difference. Manipur, on the other hand, also we see increase in coverage of nutrition sensitive interventions along with adequacy of diet. So we need to really study these 3 states, what's going wrong, at least in these 3 states which are doing so well and where mothers are educated. Next slide. So some observations, these were done with reference to understanding what is the trend and what should be the program direction. Of course, there are a lot of limitation in such a trend study, but it does give some inputs to go ahead with the program improvement. As I mentioned, substantial increase in coverage of nutrition sensitive intervention, and of course, it can be attributed to government national programs. MCH services, we have to still work towards improving coverage to 90%. Infant and young child feeding practices, as I mentioned, we need to make effective breastfeeding and complementary feeding. I think we need to strengthen the policy and action plan, possibly within POSHAN Point 2. Selection of food items is a problem because we do see an obesity and overweight trend going up in women and children. So this area needs to be probed in. We also need to probe in when we are measuring adequacy, how many overweight and obese children come in that group, and we overestimate coverage of children following adequacy. Women's education, when it increases, we also see obesity is going up in the percentage. When the percentage of women with education of 10 years goes up, We also see obesity and overweight goes up, which shows that possibly these women have increase in decision-making power and purchases and are influenced more by advertisements of food, and they buy high-fat sugar food items. Like I understand, they also buy a lot of biscuits because it's not covered under the IMS Act, and it is bought for the family but fed to the children. And maybe there is a shift in aspiration of these caregivers who are very well educated. They rather have mobile phones than put money for buying food for the children, purchase snacks, replace home cooked food. These are some of the issues that emerge from this data when you study it. There's a need for increased attention to direct nutrition interventions and combining them with nutrition sensitive, which is occurring. Maybe when these nutrition sensitive indicators are going up, what is happening in those families where there are children, pregnant women and children below 2 years? Maybe it is time we look at these families as high risk of undernutrition, and also ensure the convergence of nutrition sensitive interventions reach these. The coverage may be high in the states, but these families may not be receiving those services. Coming to again, because the education is going up of women, school girls in school, I think there is a need to prepare them for future and curriculum to include nutrition through life cycle. So it's only a trend study which gave the program directions, which will be substantiated by the IFPRI study, which is much more in detail. So the interpretation of trend study and observation interpretation has its own limitations, but it will help us to move forward. Thank you very much.
Thank you so much, Dr. Veer. Now I request our last presenter for today, Dr. Rasmi Awala, and she'll be presenting on supporting policy and programmatic decisions for nutrition in India, analysis of subnational success case studies. Dr. Awala is a research fellow in IFPRI's Poverty, Health and Nutrition Division. She has 10 years of experience in conducting implementation research. She leads the stream of work on subnational success case stories on improving child nutrition in India. Over to you, Rasmi.
Hi, thanks, Isha. I hope everybody can see my screen.
Yes.
So this work, yeah, thanks. The work I'm about to present is based on the success case studies that we have done prior to the release of NFHS 5, as well as I'll give you a flavor of what we are looking at present once the NFHS 5 has come through. And this work is in collaboration with several individuals and several IFPRI team members, and I'm presenting this on their behalf. Okay. So in 2016, when we had the NFHS 4 data, and then we saw that stunting had reduced at the national level, but we also saw that there was variability among states in how stunting declined. We went about to look at how these changes happened, and the methods we used were could be characterized fit into these 4 questions. We started asking, how did determinants of stunting change over time? And we created a data timeline looking at between these 2 time periods, and 2006 and 2016. And then we said, what factors contributed to stunting decline? And for this, we conducted regression decomposition analysis to identify factors that contributed to changes in stunting. And then we did a review of policies, looking at published and gray literature, and conducting interviews with different stakeholders. And the stakeholder interviews gave us information on what drove the policy changes, what happened, and how it happened. We got it from the literature, and why it happened, we got information from the stakeholder interviews. And our entire studies were based on the using the conceptual framework of the UNICEF's conceptual framework, looking at various immediate and underlying determinants. And Dr. Veer has already set the stage for all the various determinants, so I don't have to go in detail. So what we find is the key takeaways in these 4 state case studies. We did this study in Chhattisgarh, Gujarat, Odisha, and Tamil Nadu. Across these 4 states, what we find is the stunting reduction can be explained by improvements in health and nutrition interventions ranging between 11 to 23% among these states. Improvements in household conditions ranging between 22 to 47%, and improvements in maternal factors, which range from 15 to 30%. In Odisha and Chhattisgarh, improvements in health and nutrition interventions contributed to the majority of change, whereas in Tamil Nadu, household and living conditions and maternal factors contributed to changes. So the bottom line is multiple determinants across board improved. So we need multi-sectoral solutions. But what drove these changes? At the state level, there was a vision for achieving improvements for across these sectors. There was an enabling environment which was provided through leadership at the state level, implementation of various state level programs in addition to the national level programs. And there were catalysts and champions within the system and outside of the government system who were helping to drive improvements in these various programs. So together, these multiple factors came together to facilitate change in stunting reduction. So what does this mean for going forward in terms of facilitating changes for India's policy and programmatic environment? What we know is there is no dearth for programs and policies in India across board, whether it is for immediate determinants or for underlying determinants or for interventions. For example, we have health and nutrition services between the health department that delivers several interventions, micronutrient supplements, antenatal care, immunization. ICDS provides food supplements, counseling services. Then there is PDS program that provides subsidized food. There are cash transfer programs such as PMMBY, livelihood programs such as NREGA, and there's sanitation program under Swachh Bharat Mission. There are other programs such as NDM, programs to improve infrastructure, electricity. There are all these programs that are available. So what is needed? We need all these programs to converge on the first 1,000-day households and with families with adolescents to form a circle of protection, if you will, and to enable improvements in child growth and development. Now, this is what we found in looking at data at 2006 and 2016. So how do these things pan in when we see the NFHS 5 data? And I won't go into much details about that because Dr. Veer has already told us how stunting changed. But among the 19 states and union territories, we see improvements in stunting in Manipur, Sikkim, and Bihar, the major improvements. Manipur and Sikkim saw 6 percentage point improvement, whereas Bihar, there was 5 percentage point improvement. There are 13 states that have seen stall in progress or increase in stunting, and we have to unpack the reasons for those. So what we said is, now Bihar is a state with a large population, it's a big state. So we said, let's look at what has contributed to changes in stunting in this particular state. And what I'm about to share are very preliminary findings, and which basically we are looking at the changes in the various determinants they're based on and using the available data. And here we are partnering with the NITI Aayog, Care India, and UNICEF in looking at the success story of Bihar. We see that between 2006 and 2016, there was a stunting decline in Bihar from 55 to 48, but between 2015 and 2019, the decline has been greater in terms of annual average rate of reduction. So how do the different determinants stack up in terms of changes when we look at Bihar as a state? So if on the left side, the graph shows improvements in the immediate determinants. There has been substantial improvement in women's low BMI. So women, which means that women, fewer women are now underweight. In terms of infant and young child feeding practices, the picture has been mixed. The early initiation of breastfeeding declined, exclusive breastfeeding improved, adequate diet improved, but it is still only at 11%. So the focus on infant and young child feeding practices needs to continue. However, overall, we see improvement. On the right side, if we're looking at the underlying determinants, we see there are large improvements in sanitation. There are improvements in electricity and in that relate to the household conditions. If we look at women's conditions, there have been improvements in women's education. Now around a third of women have about 10 years of education. There has been a decline in women getting married before 18 years. So overall, there have been improvements. Of course, again, these are all the levels are still low and need improvement, but they have improved. In terms of coverage of various interventions, we see that there again, across board between pregnancy, delivery period, and childhood, there have been improvements. The improvements have been, particularly in the pregnancy period, there have been quite a few improvements, but the 4 or more ANC still is less than 25%. But several interventions improved. Similarly, at the delivery point, between delivery and postnatal care, also there have been huge improvements. They're all reaching above 55%. In childhood, also considerable improvements have been seen in immunization, vitamin A supplementation, care during illness, and in counseling. But of course, there is still scope for improvement on various interventions. That's to be considered. So we wanted to unpack what the various determinants of how are these improvements taking place. And this is, again, like I said, these are very preliminary findings. Until we have the unit level data, we will not be able to do the regression decomposition analysis to be able to say what proportion of changes, improvements in these various domains have contributed to changes in stunting. These preliminary findings here are based on our literature review and our ongoing interviews with different stakeholders. So what we find is, again, in Bihar, in addition to implementation of national programs, state level initiatives have been undertaken, whether it is related to girls' education, women's empowerment, or sanitation, and for various coverage of interventions. So there have been several state level initiatives. And then there have been huge investments in infrastructure development, particularly improving the road connectivity. And employment opportunities have improved outside of the agriculture sector around the same period. And poverty has declined from 55% to more than a third in 2012. And this is the time period after 2005 is when the new leadership has come into being in Bihar, and the focus has been on development agenda and maternal and child health. And there has been overall multiple development partner support in helping in system strengthening efforts in various related to health and nutrition programs. So I'll stop here for now, because this is all we have. Again, like I said, preliminary findings as far as Bihar story is concerned, and we ask you to stay tuned. We'll continue to work further and bring back to you additional findings. Thank you. Over to you, Isha.
Yeah, thank you, Rasmi. I'm going to take over. We're really sort of coming to the end of time. And so I want to, apologize to participants and to our panelists who are going to offer some comments about these pieces of work that, we've sort of gone over time. But I think this was, really so important for us to hear the findings from, the deep research that at least this set of groups is doing. I think it reinforces our commitment to sort of share and create these platforms for sharing and hopefully for dialogue, although we clearly need more time for that. I'd like to invite a few panelists who've been, very involved in looking at and working on NFHS data to come in and offer some remarks. I think we're just going to try to maybe continue until about 3:15. I hope that's okay with the panelists, especially so we can make sure to get their insights. So let me first call on Professor S.K. Singh, who's really behind the NFHS team and leading at least one of the principal investigators on the NFHS itself. Professor Singh is with the International Institute of Population Sciences. Over to you, Dr. Singh.
Thank you, Dr. Purnima. Thanks a lot. Good afternoon to all the distinguished participants. A very good speaker who have covered a wide range of issues. I would like to congratulate Dr. V, Dr. Sinha, Dr. Reshmi, and Dr. Nair for covering a wide range of issues without even looking at the unit level data. Whatever we have put in public domain, they have extensively used that and captured changes in those indicators over time, and changes in key drivers of nutrition among children in India, even policy changes and factor contributed towards policy changes. But I would like to give emphasis on three important points. Whenever we are looking at these changes, we should first notice that gap between NFHS 4 and NFHS 5 is hardly 4 years. And we have captured children under age 5. It means 20% children, estimates of 20% children may be overlapping. That is the first point which I would like to mention. Second important point, a state like Tripura and Telangana, where we are getting deterioration, significant deterioration in stunting as well as underweight. These are the states where Tripura has changed from 4 districts to 8 districts. Telangana has changed from 10 districts to 31 districts. And since we have been doing district level sampling, that is why the entire composition of population has changed. Otherwise, if I am looking at nice aggregate level, there is a quite impressive picture. In fact, we should not read too much. We should not expect very profound changes in nutrition indicators over a period of 4 years. If you look at the 5 indicators, stunting, wasting, underweight, all 3 has gone down from NFHS 4 to NFHS 5. Of course, there are variations across a state, but I will suggest everyone don't look at point estimates. Please look at interval estimates. If you are looking at interval estimates, only Bihar and Manipur has significant decline. Tripura and Telangana, out of first page states, has significant increase. In remaining all states, there is an insignificant change. That is why even media colleagues, when we released, our Honorable Minister released on 12th December 2020, first page reports for 22 states, media started writing something. Suddenly, I will have to attend 2-3 television programs at national level and clarify this issue, that only 4 states are there showing significant change. If you look at stunting at national level, what we are going to release very soon, I have already presented, it has been appreciated by Honorable Minister on 1st September. He was supposed to release it yesterday, because in between that he changed his mind to get it released by Honorable Prime Minister, who could not spare time. Now probably it will be on 5th. The decline in stunting, wasting, underweight at national level is there, but only thing is that it is very insignificant. That is not a very profound decline. On the other hand, all drivers of nutrition, whether you are looking at breastfeeding, early initiation of breastfeeding, what Dr. Veer has already presented, early initiation of breastfeeding or supplementary feeding, maternal health intervention, child health intervention, women's empowerment, was all domain of interventions which are expected to influence or which are the key drivers of malnutrition has improved significantly across the country over last 4 years. Only problem is two indicators are going in negative. Overweight has increased, overweight among children has increased significantly, and that has increased especially in Ladakh, Lakshadweep, Mizoram, Arunachal Pradesh, Sikkim, and Jammu and Kashmir. Here it is going above 10%. That will be a problem. And anemia among children, somehow our Anemia Mukt Bharat program has not been able to address anemia at grassroots level. But if you look at that, while presenting to Honorable Minister, I disaggregated it by mild and moderate anemia. If you look at mild and moderate anemia, from NFHS 2 to NFHS 5, there has been a significant decline from 51% to 38%. Our SDG target is around 33. But the only problem is that if you look at any anemia, 10 gram per deciliter to 10.9 gram per deciliter, there is an increase of from 23% to 29% from NFHS 1 to NFHS 5. That's the real problem. That is varying drastically across local and regional situations are playing role. Harvesting, non-harvesting season are also playing role. Anemia is not clustered in certain group. It is cutting across rich, poor, everyone. That is why probably government will have to think slightly more. What is happening? Why we are not? We have also done a lot of literature search. We could find out that only 45 to 50% of anemia among children and women in our country can be addressed by iron supplementation. Remaining 50 to 55% anemia has some other reason: nutritional anemia, Mendelian anemia, sickle cell anemia, various kind of infection like hookworm, etc. Even our genetic deficiencies, that is beyond control of our Anemia Mukt Bharat program. That is why anemia is going to be one of the major challenge, major focus area. Otherwise, in case of a stunting, wasting, underweight, we are going in right direction. Yeah, only question is that state-wise differentials are there. One of our participants has presented Bihar as a success story. My humble suggestion is that Bihar and Meghalaya should not be presented as humble story, because still Meghalaya, Bihar, Uttar Pradesh and Jharkhand, all 4 states, stunting is above 40%. And if level is too high, reduction is quite easy, quite feasible. That is why even if you are computing decadal decline, you are computing per annum decline, that is going to be higher if your level is higher. Real challenge is that if our level is going down, we are bound to have further improvement with a slower pace. That was the only point which I wanted to make. Otherwise, and please, whenever you are looking at all these 5 indicators, whether you are looking at stunting, wasting, underweight, anemia or overweight, please look at 95% confidence interval. Please don't rely on. We have given all first phase state reports are there on the website. Second phase state reports will be on the NFHS website within a fortnight. I am pretty sure if Honorable Minister is releasing on 5th, fact sheet we will be putting on 6th or 7th, and state reports by 20th. And all state reports has a value of relative standard error. Simply R plus minus 2 relative standard error. You can develop CI and plot it wherever there is overlap in that difference is insignificant. Then you will find a true situation. Country is moving in a very right direction. Yeah, definitely last 18 to 20 months has slowed down the food supplementation, which is distributed through large network of ICDS system in the country. But that is the pandemic situation, that services can be delayed, services are not denied. Even all health services, people were suspecting that it will be declined. But we are evident that when you will get the report of NFHS 5, all indicator for national level as well as second phase states, you will realize that services are delayed but not delayed. And that is the true in case of ICDS also. And that is why anemia and food supplementation, these are the two real problems, but that cannot be generalized. Thank you, Dr. Purnima. Thanks a lot.
Thank you, Dr. Singh, and thank you as always also for your great collaboration with the broader team on the state profiles and other things. We take your points very seriously. I'd like to now call on Dr. Robert Johnson, who's with UNICEF. Robert, your comments, please. About 5 minutes, and then William after that.
Thank you. So yes, I'm so pleased to have this chance to be able to congratulate you all for the release of the state nutrition profiles, just on the eve of the NFHS 5 the release. And I'm really happy to note that all the NFHS 5 data will be available for review on the Ministry of Health's nutritionindia.info website as soon as these last rounds are released. So COVID arrived in January 2020. Now it's been 21 months, and the remaining data coming from the NFHS 5 will be the first public information on the nutrition conditions of the country since the start of the pandemic. And we can see from the regular ongoing monitoring that there's been a strengthening in social safety nets and food distribution. But we know at best, this is a continuation of diets as they are. And at worst, this marks a significant reduction in the diversity of diets. So an increase of monotonous diets, right? And we know that these nutrient poor diets do not provide the necessary vitamins and minerals for growth. And we also can see that international studies have predicted that COVID will lead to increases in malnutrition and low birth weight. So looking at infant and young child feeding, from a review released by UNICEF this week, we can see how poorly India has fared to feed its children with the correct frequency, diversity, along with caring and hygiene practices to prevent malnutrition. As Dr. Veer has noted, only 21% of children have a minimum dietary diversity, and only 42% have a minimum meal frequency. And there's been very strong, interesting work on the cost of diets recently. Many of these reports, research shows that poor families cannot afford a nutritious diet. And it's not just the cost of diet, but it's also issues of opportunity costs and the convenience of feeding, the preparation time, and also cultural practices. The UNICEF IYCF report shows presents that women are still assigned the responsibility for feeding children, but they do not have the necessary resources and autonomy to ensure that children are given nutritious diets. And like has been noted, Parle G biscuits have recorded record profits during the pandemic. So on one side, as dietary diversity has contracted from market forces, on the other side, the market was able to respond and provide substitute foods, which comes in the form of non-nutrient dense, high sugar biscuits, which is a terrible, terrible result. We also know that there are seasonal variations in acute malnutrition. From the survey data, program data, and longitudinal data, we can see that acute malnutrition can double between the winter seasons and the rainy season. Also, from the work that has been done by CARE in Bihar, we can see seasonal differences in exclusive breastfeeding and consumption of important vitamin A rich and foods, fruits and veg, and green leafy vegetables. So we know that there's a lot of variation in a child's diet, right? There's a large number of services and essential nutrition behaviors that we can improve upon quickly. So remarking on SK Singh's point that we can't expect so much change, but there are indicators of infant young child feeding in children from 6 to 23 months that we can expect to see changes in quickly, right? And also in the essential health and nutrition indicators, where we do need to have robust data to monitor what are our achievements. And what we see in the HMIS is that there are many indicators that continue with little or no fluctuation throughout the pandemic. But then a lot of this change can be hidden at the national level. But we do, echoing what Divya said, we do need valid data for benchmarking HMIS against survey data. So to close, I would like to recognize the strong work of IIPS to continue to make efforts to improve the quality of nutrition data, and to echo what a lot of others have said, that we do need to have regular, accurate data that's not biased by seasonality to monitor our improved programming and our improved outcomes from the response. Over.
Great, thank you, Robert. I think you signal in all of your remarks the passion for data that many of us share, but not data for the sake of data or just for research, but really data to help move programs forward as well. Our last commentator for the day is Professor William Joe from the Institute for Economic Growth. William, I hope you are still with us. Again, very grateful for IEG as well to be partners in this data collaboration and on our profiles. So I welcome you to offer some remarks now.
Yeah, thank you, Purnima. Thank you so much. And let me begin by congratulating you and your team for this fantabulous job. I think it's really very thoughtful planning. You brought in all the institutional partners to work on this. And in my view, it cuts down the task for the nutrition community to understand some of these trends, patterns, and to look at also the determinants. So I will say that this time the fact sheet has been much bigger in terms of its scope. It's more comprehensive and much better in terms of its planning and information content. So let me again congratulate you and your team for this fabulous work. Given that this is a very challenging task, and I would like to at this point reiterate what Professor Singh has mentioned, we have to be aware of the comparability of the data, the estimates, and that is something which is very important. As a scientific community, we have to communicate it more effectively to policymakers as well as the laymen to understand how the things are evolving. So that's a very important point which we have to consider. Given this, also the presentations which we had today were very interesting, very well connected with the theme as such. In my view, I think one of the most important aspect is to address how we can use this data more continuously for program monitoring. So that is somewhere I think Divya has tried to look at HMIS, and it shows that the trends are improving. There is more comparability. One major gap is if we can bring in more indicators from nutrition side for comparison within HMIS. So probably if it will be difficult to bring all the ICDS all together within the HMIS convergence thing, at least we can initiate by 2 or 3 indicators which can be part of the HMI system. So that is something which could be considered as we go forward. I think there was also like a lot of queries around how we can get this data and queries around looking at the causal effects through regressions and all. And as Rasmi has shown, it's like very difficult. The district level analysis also shows that there are certain things which are still to be explored. And like Robert was also mentioning that there are factors such as seasonality and all, which are like very difficult to comprehend and until we do a very detailed analysis. But I will encourage all the participants to look at some of these fact sheets as well as visit the Nutrition India info dashboard for more information around some of these covariates, and they can study this in more detail. So these are like interesting sources which gives you much a detailed analysis at the district level. Going forward, I think Dr. Sheila, she reviewed it excellently, the entire indicators. And from her policy directions, I think convergence clearly comes out as very important factor. Plus, as Robert was mentioning, dietary diversity, as well as like Professor Veer was mentioning, dietary diversity is an indicator which India has been struggling with. And that is something going forward will have more implications. It is not only about poverty, but rather it's a cross-cutting issue. Even among better off households, we don't see that kind of diversity. So this is something more behavioral, more intrinsic to the household itself. So which is a difficult area for policymakers, but needs to be focused upon. Apart from this, I think one other aspect which was striking to me was, as Divij has highlighted, the problem of poverty and undernutrition, it's well understood. But I think the problem, as he shows, urban areas are even more vulnerable than rural areas. So our programming focus should also come towards urban areas, urban poverty, slums, which can then help us to address some of these urban undernutrition challenges. And finally, to conclude with, I would just like give my thoughts about this trends in anemia prevalence. I think that is something which is a very challenging area, and India has been struggling with this for last 4 or 5 years. One positive message that we can find from NFHS on this is the coverage of different beneficiary groups in anemia supplementation, IFS supplementation efforts, that has improved. And earlier the program focused mainly on pregnant women group, but now children, adolescents, they are being focused upon, and that trend is actually improving. So that's a good sign in that sense. But of course, anemia is very challenging because there are other non-nutritional causes, non-supplementation related issues which needs to be addressed. So broadly, I think NFHS opens up a wide range of issues for discussion. And as Professor Singh is mentioning, once we get the entire country level picture, it will be good to see how India is progressing at the national level, what trends are emerging, and whether we are able to withstand some of these great disruptions caused by COVID. So again, congratulations to the team and a very interesting effort. We look forward to work more on this. Thank you, Purnima.
Okay.
Thanks so much.
Thank you so much, William. And again, thank you, Professor Singh and Robert, for your very, very thoughtful comments. I should say there are a few questions in the chat box asking about when the CNNS data will be available in public domain, when the NFHS 5 will be in public domain. And we know that with NFHS, there is a path to the release in public domain, and that path is usually a few months after, after the release of the initial fact sheets, etc. But I think there are questions, important questions here to also just place on the table about ensuring that all data that is collected and that is likely useful for public policy should very much be in public domain. And we await, hopefully from the Ministry of Health, the CNNS data also eventually coming out in public domain, although it is available to any researchers who would like to access it. So again, if somebody wants to drop us a note, we can connect you with the right teams at UNICEF. Robert, I hope that's all right to state, who can share what is currently accessible for analysis, even though it's not in public domain. So I want to apologize, friends. I know there are comments and I know there are questions, but we are very over time at this point in time. For me, it just signals, the fact that all of you are here is signaling phenomenal interest in this challenge area. The fact that we have we've had at least a few people volunteer to present signals a phenomenal interest in sharing your research in a public platform. And so I would like to, really just thank the team that organized it, thank our partners, Niti Aayog, IEG, IIPS, UNICEF, and ID Insight, who've been part of developing these products, but who are also part of analysis collaboration networks. And I invite others to share with us if you're doing work that you would like to share on a public platform that relates to NFHS, please reach out so that the next webinar that we host can also feature your work. I'd also like to take this opportunity to remind everybody here that in December first week, we are hosting a conference called Delivering for Nutrition. And we invite you all to, again, visit our website and consider registering both to attend the conference, but there are still 2 weeks when you can submit an abstract on your own research. If you would like to do that. We will close abstract submissions in middle of October 15th. Very big thank you to the POSHAN communications team that has brought this event together. Isha Saraswat, Fahim, Vinny Vaid, And I don't know who else has been on the team, but thank you, especially the three of you, so much for holding this together, bringing everything together, and pulling this off. I know that at the peak of the webinar, we had over 200 people here, and more will view it when things are available in public domain. Thanks, everyone. Have a good afternoon and enjoy this sort of closeout for Poshan Ma 2021 from the research community. Thank you very much.
Thank you, Dr. Purnima. Thanks a lot.
Thanks.